The teaching objectives in today's segment are, number 1, explain the epidemiology of stroke. Number 2, describe the types of vascular damage to the brain that cause vascular dementia. Number 3, explain the difference between vascular dementia and Alzheimer's disease, a very important distinction. Number 4, define diffuse Lewy body disease. Number 5, describe common presenting symptoms for diffuse Lewy body disease. And 6, describe the differences between Parkinsonism, Alzheimer's disease, and diffuse Lewy body disease. First of all, we know that Alzheimer's disease is slow, progressive intellectual decline over a period of years. Typically, the Alzheimer patient does not demonstrate focal neurological findings. Usually, in Alzheimer's disease, intellectual symptoms precede the psychiatric symptoms, and amnesia seems to be the first symptom that you see. As well, you must demonstrate that the patient was not an alcoholic, did not have a past history of alcoholism. Otherwise, it's not fair to say that the dementia is not necessarily caused by alcohol abuse. Let's begin with vascular dementia. What is vascular dementia? It's sufficient acute or cumulative vascular damage to produce cognitive loss. In other words, you have to demonstrate that the brain was damaged due to vascular disease, and as a result of that, the patient had intellectual impairment. The diagnostic requirements for calling somebody vascular dementia are, first of all, of course, you have to demonstrate that the patient has dementia. Secondly, you have to demonstrate that they have cortical or subcortical infarctions, and we're going to talk about that in some detail in just a little bit. And thirdly, and most importantly, you have to demonstrate a temporal relationship between the strokes and the dementia. For instance, if a patient was demented for 5 or 6 years, and then all of a sudden they have a stroke, you can't call that vascular dementia. The most likely diagnosis is Alzheimer's disease with a stroke. What you want to demonstrate is as the person had strokes or vascular injury to the brain, then they had the onset of their dementia symptoms. Let's begin by reviewing the epidemiology of vascular dementia. It has been said to be the second most common cause of dementia in people over the age of 65. Newer science may indicate that actually it's the third or fourth most common. However, historically, in the old days, back in the 1960s or the 50s, it was thought to be the most common cause of dementia. Whenever anyone lost their intellectual function, they were said to have, quotes, hardening of the arteries. We now know that it's the second or third most common cause, with Alzheimer's disease causing the lion's share of dementia. In fact, only 5 to 20% of all dementia, based on clinical series, is attributable to vascular disease. We do know, however, that many patients have several disease processes with dementia, and vascular and mixed dementia is fairly common, accounting for anywhere between 7 to 18% of all mixed dementias. In reality, the newer autopsy studies indicate that no more than 5 or 10% of all patients dying with dementia have, with postmortem examination, documentable vascular dementia. Consequently, the epidemiology of vascular dementia has changed over the last 20 years, and we know that it is less common than was previously thought. Likewise, the nomenclature associated with vascular dementia is sometimes confusing. You've heard the term multi-infarct dementia or ischemic vascular dementia. This refers to patients with multiple cortical injuries. Likewise, there's vascular damage to subcortical structures, which is described as Binswanger's disease, subcortical arteriosclerotic leukoencephalopathy, leukoariosis, subcortical small vessel dementia. Actually, there's a laundry list of these different terms. This confusing terminology results from the fact that multiple different kinds of vascular damage in different locations can produce dementia. Let's briefly review some of the different kinds of strokes and other type of vascular pathology that you can see in the brain. First of all, the most common type of ischemic or vascular damage to the brain are what are referred to as embolic infarcts. A stroke, by the way, is just death of brain tissue. Same thing for an infarct. It's just basically the death of brain tissue resulting from cessation of blood flow. Embolic infarcts are common, often seen in the cortex, in the outer layers of the brain. frequently resulting from tiny blood clots originating in vessels in the neck or in the heart. Lacunar infarcts, on the other hand, are slit-like small, tiny strokes located in deep structures such as the basal ganglia and thalamus. They result from hypertensive damage to small blood vessels. White matter ischemia is very commonly described on brain imaging studies. It's typically seen around the ventricles, and again it's due to small vessel disease, especially from hypertension. Anoxic brain damage, on the other hand, is injury due to cessation of blood flow or oxygen, such as individuals who have had cardiac arrests and have not regained blood pressure for at least 3 minutes. Specific kinds of brain regions are sensitive to low oxygen and low blood flow, especially the hippocampus. And finally, hypotensive brain injury. This is when the heart is no longer able to pump sufficient blood to the brain to keep the whole brain alive. In that particular instance, vulnerable regions, such as what are termed watershed zones, or regions that are at the end of vascular supplies, or sensitive regions, such as the hippocampus, are damaged by this low flow situation. Hypotensive injury is fairly common in patients with severe cardiac disease. All of these different types of vascular pathology can contribute to the global injury to the brain that predicts vascular dementia. Let's begin by talking about atherosclerosis. Atherosclerosis is oftentimes referred to as hardening of the arteries. In this graphic that you see here, on the top is a normal basilar artery. You can almost see the black background through the artery because it's clear, translucent. On the other hand, in the bottom part of your field, you see an atherosclerotic basilar artery. It looks rigid. It is not translucent. It's hardened by cholesterol and other debris which has been deposited within the blood vessel wall. In the next slide, you see what this would look like under the microscope. In the top of the field here, as denoted by the arrow, you see a normal 3-layer muscular artery. And in the bottom part here, you see that that artery is markedly expanded with all of this crystalline debris. That's cholesterol, which is deposited within the blood vessel wall, referred to as atherosclerosis. This cholesterol plaque, as it's referred to, can sometimes either separate itself from the vessel wall and then move off into the circulation and occlude a smaller vessel, or if the outer layer, what's called the inner layer or the intima of the blood vessel, is torn off the top of this plaque, a blood clot will form on top of the plaque, which is roughened and not smooth, and that blood clot will either grow to occlude the blood vessel, or it will fly off into the circulation and occlude a smaller vessel downstream, producing a stroke. This type of atherosclerosis is very common in older people and is a common cause of stroke and vascular injury to the brain. In the next graphic, we see what a stroke looks like. In the parietal occipital region, under the NL, or normal sign, you can see normal convoluted brain tissue. To the right, we see that that brain tissue is severely disrupted and lost. This is typical of a stroke in the right cerebral hemisphere in the distribution of the right middle cerebral artery. This patient would probably be paralyzed on the left side of their body, although they would still be able to speak and understand spoken word. Because remember, the dominant hemisphere in a right-handed person is on the left side. On the next slide, however, we see a stroke located in the left inferior frontal region. Here you see that hole-like opening in the convolutional surfaces. This is from occlusion in a specific vessel in the middle cerebral artery, and it knocked out what's referred to as Broca's area, or the motor speech area. This patient would not be able to speak, but would probably be able to understand. This is in contrast to the next individual, where here we see the set of forceps expanding a large stroke located in the temporal and parietal region on the left side. This is what is referred to as Wernicke's area, or the part of your brain that understands spoken word. This patient may have been able to speak some, but would not have been able to understand what was being said to him. This person would have had a receptive aphasia. These are different kinds of strokes in different locations, all caused primarily by atherosclerosis, occlusion of vessels either in the neck or the head by this cholesterol debris within the lining of the blood vessel wall. What we see in the next slide then is a review demonstrating that the atherosclerosis is located in large caliber vessels. It's located on the inside portions or the intima of the vessel. It's produced primarily by high lipids, diabetes, and hypertension, and it results in stroke. We're going to compare atherosclerosis to a second kind of vascular disease called arteriolar sclerosis. This is due to hypertension, and it's seen in small penetrating vessels. And it's not located in the inner layer, but rather in the middle layer, the muscular layer that controls blood pressure. It results from hypertensive injury, and it produces lacunes and hemorrhages. In the next slide, as we think back to that previous slide showing a blood vessel, where it had this sort of pink, healthy look to the normal vessel wall, here we see this blue debris that is deposited in the middle of the vessel wall. The arrow points to the blue debris. This is called dystrophic calcification, and it is damage from high blood pressure. Eventually, this damage becomes so bad that the vessel either occludes or it dilates up and ruptures. When the vessel occludes, it produces what is referred to as a lacunar infarct. Here the arrow points to this slit-like lesion located in the putamen, as seen here. This is typical of a lacunar infarct. It's produced by hypertension. Sometimes, however, instead of having the blood vessel close off, what happens is the vessel ruptures, and that produces an intraparenchymal or intracerebral hemorrhage here. This hypertensive person had damage to the middle portion of his small penetrating blood vessels, and as they weakened, they leaked and finally bled into the brain tissue. This is a fairly common complication of hypertension. As you can see, this lesion would have cut the internal capsule carrying fibers going from the cerebral hemispheres down to the spinal cord. So this patient would have been paralyzed on one side. Atherosclerosis is caused then by vascular pathology in large caliber vessels due to hyperlipidemia and hypertension resulting in infarctions. Arteriolar sclerosis is caused by hypertensive damage to small vessels, which either block off and produce lacunar infarcts or bleed out and cause hemorrhages. Consequently, you can see that there are different types of brain pathology. And remember, when we're talking about dementia, the more brain tissue you kill, the more likely you are to develop dementia. So all of this different types of damage to the brain adds up to dementia. Other types of pathology also occur, however. One is what's referred to as white matter ischemia, and that's seen primarily in the periventricular zone, and another is what's referred to as anoxic brain damage. In this next graphic, we see on the right a normal frontal lobe, and on the left, we see the frontal lobe from an individual who had a cardiac arrest and for whom it took a long time for resuscitation to restore a blood flow. Brain cells begin to die after 3 minutes, so this individual who had been in full cardiac arrest for 10 to 15 minutes sustained extensive damage to neurons in his cortex. Note that the outline of the brain is still relatively intact, but when you look at the cortical ribbon, it is markedly shrunken. This is due to anoxic brain injury. Brief periods of hypoxia can sometimes cause death in the hippocampus, a part of the brain which mediates short-term recall. This is particularly common in patients who have had brief cardiac arrests for 4 or 5 minutes and then wake up and are mildly amnestic. Oftentimes, this is the result of hippocampal injury. On the other hand, another type of ischemic damage is what's referred to as white matter pathology, or periventricular leukomalacia. In this CAT scan, you notice the ventricles in the middle, and then there's this fluffy gray appearance at the ends of each of the ventricles, as denoted here by the arrows. This is the area in which the brain tissue has been lost, and it has now assumed the density of water which is in the ventricles. This is thinning of white matter in what's called the periventricular zone. If you look at this brain at the time of autopsy as seen here, what you see is this sort of gray mottled discoloration of white matter. However, overall it's rather inconspicuous to routine examination. It's fairly normal as you grow older, especially if you have hypertension, to lose brain tissue in the white matter. The exact significance of this is unclear, although these individuals do seem to have a higher rate of depression as well as perhaps dementia. So once you understand the different kinds of pathology that occur in the brain, the next step is to ask yourself the question, well, how do I diagnose this? How do I diagnose vascular dementia? And the answer to that is to, first of all, you have to complete a systematic clinical history and physical examination. You want to make sure you know how many strokes the patient had, how bad was their hypertension, how long have they had it, how long have they had diabetes, and how severe. You want to do a complete physical examination to make sure, for instance, that they don't have serious heart disease, which can cause damage to the brain. You want a careful assessment for the extent of vascular disease in the person, whether or not their EKG is abnormal, whether or not they have occlusion of blood vessels in their neck, their carotids. Most importantly, you want to do a careful neurological examination. If the patient has dementia and has focal neurological deficits, weakness on one side, clumsiness, abnormal reflexes such as upgoing toes, that's suggestive that the patient may actually have vascular dementia. The next thing you do is a CT or MRI and try to determine whether or not there is widespread serious vascular damage to the brain. And finally, you want to do the typical exclusionary testing for other types of cognitive loss, thyroid studies, folate, B12, etc., to exclude other potentially reversible causes of dementia. In short, to diagnose vascular dementia, the most important thing is to do a good old-fashioned solid clinical history, physical examination, and then appropriate testing. What are the kinds of symptoms that you ought to be looking for to distinguish vascular dementia from Alzheimer's disease in your clinical history? Well, first of all, Alzheimer's disease tends to come on slowly and insidiously. If the family or the patient give you a history of abrupt onset, that suggests to you that perhaps this might be ischemic in origin. Fluctuating courses. People have TIAs or strokes that they get worse and then they seem to improve, as opposed to Alzheimer's disease, which tends to be a slow progressive downhill decline. History of strokes is very important. When the family says to you things like, you know, he was doing quite well until he had a stroke and then he got confused and he never seemed to get better, you ought to carefully take into consideration the possibility that this might be vascular dementia as opposed to Alzheimer's disease. And most importantly, focal neurological symptoms. You know, that the individual's arm is weak or that their gait has been changed. This is suggestive of something different than Alzheimer's disease. What are the signs you ought to look for vascular dementia? Well, we can break them into three groupings: cognitive, psychiatric, and neurological. Cognitive vascular dementia patients get multiple intellectual losses just like Alzheimer's. Unfortunately, there is no distinguishing feature clinically with regards to cognitive loss that will tell you that this is Alzheimer's versus this is vascular. The two can be indistinguishable. Likewise, patients with vascular dementia develop psychiatric problems. Psychosis, depression, emotional incontinence are common features in vascular dementia. And again, you can see those in Alzheimer's and several other types of dementia. But the distinguishing feature that you might be able to hang your hat on is neurological findings. If the patient has focal neurological deficits, and if the deficits occurred at about the same time as the intellectual loss, then it's fair to suspect the possibility of vascular dementia. On the other hand, if the patient had dementia for 5 or 6 years and then they developed weakness, that's more suggestive that the patient had Alzheimer's disease and has had a stroke. The differential diagnosis when you're considering vascular dementia include things like delirium, depression, and of course other types of dementia, Alzheimer's, diffuse Lewy body, frontotemporal dementia, etc. What are some clinical features that might help you, again, distinguish vascular dementia from other common types of dementia? Well, if you're looking at the difference between Alzheimer's and vascular, remember, Vascular can have a fluctuating stair-step course with infarcts and neurological signs that are typically absent in Alzheimer's disease. If you're trying to distinguish vascular from diffuse Lewy body disease, remember, vascular patients should not have extrapyramidal symptoms, and we're going to talk about that in great detail later on in this tape. And finally, alcoholic dementia. Remember, vascular patients usually don't have a history of alcoholism, although it is possible to have both vascular and alcohol-induced dementia. Are there screening instruments that might be helpful in distinguishing Alzheimer's or diffuse Lewy from other types of dementia? Well, there is what is referred to as the Hachinsky scale, which is a published, normed scale that asks for different types of risk factors, such as emotional incontinence, stair-step progression, that sort of thing. And a score on the Hachinsky over 7 indicates vascular dementia, but it is not absolutely diagnostic. In fact, the diagnostic value of the Hachinsky scale is controversial. And again, I think the best screening instrument is a good old-fashioned physical and neurological examination. Once you've come to the conclusion that a patient has vascular dementia, what do you have to look forward to? What's the 5-year natural history for individuals with this type of disease? Well, it tends to be progressive and relentless, just like you see in Alzheimer's disease. In this one particular study that I cite here on the next graphic, you can see that almost half of folks were dead at 5 years. That's probably due to the fact that they had other serious cardiovascular disease. About a quarter, or 21%, remained independent, and over a quarter required long-term care. Consequently, the patients with vascular dementia tend to do a little bit less well than patients with Alzheimer's disease. Is there treatment for vascular dementia? Yes, there is. First of all, you want to prevent it. How do you prevent vascular dementia? Well, you prevent all those different types of ischemic damage that I showed you at the beginning of this segment. Control their hypertension, and you lessen the damage to big vessels and small vessels. You prevent atherosclerosis and arteriolar sclerosis. You want to prevent atherosclerosis by lowering serum lipids, increasing exercise, and doing other things that contribute to cerebrovascular fitness. If a patient has irregular beats of the heart, you want to treat those aggressively, especially patients with atrial fibrillation. Atrial fibrillation carries a serious risk for strokes and other types of damage to the brain and should be treated very seriously in the older patient. And finally, long-term control of diabetes is very important for several reasons. One is that it helps lower the likelihood that the patient will have serious heart disease, and secondly, it lowers the likelihood that vessels in their brain will develop accelerated atherosclerosis. So there are many things that we can do over a 10 to 20 year period, starting in the late 40s or early 50s, to lessen the likelihood that a patient's going to have vascular dementia. Once the patient is manifesting symptoms of strokes or dementia, there are some interventions that may be beneficial. Aspirin, as an antiplatelet medication, will prevent the aggregation of platelets in blood vessels that have been damaged by atherosclerosis. And finally, patients with proven blood clots can sometimes take blood thinners, such as Coumadin, although these drugs have side effects and need to be carefully prescribed. In patients with documented closure of blood vessels in their neck, what is referred to as a carotid endarterectomy, where this narrowing or closure can be surgically removed and corrected, may be beneficial. Finally, medications such as Aricept and Exelon are presently not recommended as a form of treatment for vascular dementia. In fact, presently there are several drugs that are being examined that might help with vascular dementia, although there are no drugs that are presently indicated for vascular dementia. Again, the best form of treatment is prevention. What should be the therapeutic goals in managing a patient with vascular dementia? Well, the first thing you want to do is prevent any additional cerebral infarctions. The more strokes, the more loss of intellectual function, by doing all of those things that I just talked about. Secondly, you want to keep the patient at their highest level of independence. If they have psychiatric or behavioral complications, then appropriate psychopharmacology is indicated. For instance, if the patient is delusional, antipsychotics. If the patient is depressed, antidepressants. And if the patient has behavioral complications, wandering, fighting, aggressive behavior, etc., a combination of behavioral and pharmacological interventions can be very helpful. You want to sustain the patient and the caregiver's quality of life. And finally, you must educate and support the caregivers. Remember, they are the lifeline for the patient. What can we conclude about vascular dementia then? First of all, pure vascular dementia is uncommon, probably occurring in anywhere between 5 to 10% of all patients with dementia. However, mixed dementia, including vascular and Alzheimer's or vascular and diffuse Lewy body disease, is probably common. Secondly, if you're going to diagnose this disease, the vascular damage has to coincide with the intellectual loss. Thirdly, many types of strokes can produce vascular dementia. There is not a single type of stroke or a single location for a stroke which will produce dementia in a patient. Fourthly, atherosclerosis, hypertension, and cardiovascular disease contribute to intellectual loss. These are all treatable conditions that long-term can be prevented if enough attention is paid to good medical care for our older citizens. And finally, remember, vascular dementia is partially preventable, and if they are developing symptoms, by careful attention to hypertension, diabetes, and heart disease, you may be able to slow the progression of the disease. So, in conclusion, vascular dementia is not as common as we used to think it is. However, it's still an important point in the differential diagnosis for people with intellectual loss. Now, let's move on to dementia associated with Parkinsonism. And under this heading, we're going to include straight old-fashioned Parkinson's disease and a new clinical entity which is much more commonly diagnosed, what is referred to as diffuse Lewy body disease. To begin with, let's talk about Parkinson's disease. Parkinsonism is just a global term, and it refers to a motor symptom in which the patient has slowness of movement, sometimes they have a tremor or shaking. There are many things that cause Parkinsonism. The most common cause of Parkinsonism actually is medications prescribed by guys like me. Antipsychotic medications, drugs like Haldol, Navain, they will produce Parkinsonism, but not necessarily Parkinson's disease. When we're talking about Parkinson's disease, we're talking about a degenerative disorder of the brain that produces disorder of movement and other symptoms. Parkinson's disease, if we look at the epidemiology as seen on the next slide here, occurs in 1% of folks over the age of 65. So it's not an uncommon disease. However, it's not a very common disease. Remember, although it's commonly associated with people over the age of 60, about 5% of all Parkinson's disease occurs in younger people, those individuals below the age of 40. There's no geographical or racial bias to this disease. Anybody can get it. When we talk about Parkinson's disease, the hallmark feature are what are referred to as extrapyramidal symptoms or an extrapyramidal syndrome. What is an extrapyramidal syndrome? Well, it turns out that we have two motor systems in our brain. One is referred to as the pyramidal system, and the other one is referred to as the extrapyramidal system, or meaning it's not part of the pyramidal system. Where are these two systems located? Well, the pyramidal system is located in your motor strip. The extrapyramidal system is located in deeper structures such as the basal ganglia and the brainstem. The pyramidal system is involved with voluntary motor function. In other words, the pyramidal system is what allows your brain and your thoughts to tell your hand to move and grasp. The extrapyramidal system is involved with motor tone and position. The extrapyramidal system allows you to stand erect, to hold on to things without crushing them, and to shake somebody's hand without overdoing it or underdoing it. It is beyond the thought process. In other words, the extrapyramidal system works without you thinking about it. Dysfunction of the pyramidal system produces paralysis. Dysfunction of the extrapyramidal system produces tremor, rigidity, and abnormal movements referred to as dyskinesia. On the next slide, we see a picture demonstrating the lateral cerebral hemispheres. And here we see overlying the motor strip is a sign that says pyramidal system. This is where pyramidal neurons are located, and these motor neurons tell your arms and your legs to move when your thoughts in your brain issue the commands. On the other hand, in the next slide, we see a cut coronal section on the top with a label in the deeper structures referred to as the basal ganglia, where the extrapyramidal system is located. These deep structures control tone and also quality of movement. So therefore, damage to these brain structures can cause tremor or rigidity. Pyramidal versus extrapyramidal. This is a very, very important distinction. Going back to our slide then, we see that when we have damage to the outer motor system, the pyramidal system, it causes paralysis. But in contrast to that, when we have damage to the basal ganglia, or more important, to the brainstem, things like the midbrain, pons, and medulla, where dopamine and norepinephrine-producing nerve cells are located, then we can see tremor, rigidity, and dyskinesias. These are hallmarks of Parkinson's disease. In fact, Parkinson's disease is caused primarily by dysfunction of brainstem structures that control extrapyramidal movement. On the next slide, we see a brain which is cut right down the midline to demonstrate for you the brainstem. And here we see three labels, DA, NE, and 5-HT. The DA label stands for dopamine, and it's over the midbrain. The NE stands for norepinephrine, and it's over the pons, where the locus ceruleus is located. And 5-HT stands for serotonin. It's located over the medulla. These three brainstem centers are intimately involved with the pathology that you will see in Parkinson's disease, and to a lesser extent, diffuse Lewy body disease. The dopamine center is extremely important for extrapyramidal function in maintaining motor tone. Here we see a section through the midbrain where that DA or dopamine is produced. You will notice here is where the cerebral peduncle is located, and immediately above it, here is this dark line, which is the substantia nigra. This substantia nigra is composed of pigmented brain cells that make dopamine. These brain cells are very important in maintaining proper muscle motor tone through the extrapyramidal system. These brain cells are damaged in Parkinson's disease, which is why patients become stiff and have problems maintaining proper tone. In fact, Parkinson's disease is a disorder of movement, mood, thought, and cognition. We tend to think of Parkinson's disease only in terms of it being a disorder of movement, but in reality, it's much more. If we're talking about the diagnosis of Parkinson's disease, there are a few basic inclusionary symptoms that you have to find. First of all, you must demonstrate that the patient has bradykinesia, which means that slowness or poverty of movement. In other words, it's hard for this patient to get going. In addition to that, you're supposed to demonstrate that they have one of three findings. First of all, rigidity, that when you try to move their limbs, they seem rigid. Or a tremor, the characteristic Parkinsonian tremor. Or postural instability, that they seem to have trouble getting up on their feet and getting going. But remember, the most important feature that you must demonstrate to say that somebody has Parkinson's disease is bradykinesia, slowness of movement. When we start asking the question then, well, how come they have disorder of movement, mood, thought, and all those other things, we have to go back to the brain centers that are damaged. There are three basic brain centers that are damaged in Parkinson's disease. The substantia nigra, which produces dopamine, and the symptom that results from this dopamine deficiency is motor impairment and psychosis. The second is the locus ceruleus, which is located in the pons and produces norepinephrine. This is essential to maintaining mood. Damage to this brain region by Parkinsonism produces depression. And thirdly, the raphe, which makes serotonin, also, when it's damaged, produces depression. This is why patients with Parkinsonism are improved when you put them on a serotonin reuptake inhibitor. The next slide demonstrates the effect of Parkinsonism on the midbrain. On the left is a normal substantia nigra, seen here with the arrows. Note the discrete, dark, black pigment. On the right is a brainstem from a patient with Parkinsonism. And notice that discrete, almost penciled-in dark line is gone. And what you get is this sort of fuzzy brown appearance. That fuzzy brown appearance is due to the pigment that used to be in brain cells that's now spread out into the brain tissue because the brain cells have died. This person would be stiff, would have difficulty getting up on their feet, would have a tremor as a result of damage to these brain cells in the substantia nigra that make dopamine that is pivotal in maintaining proper tone through the extrapyramidal system. In addition to that, this same patient would have damage to the locus ceruleus. On the top, you see here an arrow pointing to the locus ceruleus, this small brown spot. And on the bottom, the arrow points to the place where the locus ceruleus ought to be, and now it's gone. And the reason that it's gone is that these pigmented norepinephrine-producing brain cells have been killed by the disease process. And consequently, this patient now has a deficiency of norepinephrine, and as a result, this patient would demonstrate depression. That's why antidepressants would help improve this patient's mood. What's going on in these brain cells? Well, in the next slide, we see the view through the microscope of a brain cell that contains a Lewy body. Here you see dark brown pigment in a brain cell in the middle of the field. And right in the middle of that brain cell is this red inclusion with the clear halo around it. And that is what is referred to as a Lewy body. This pigmented dark black-brown cell is what gives the substantia nigra its dark brown-black appearance. When this cell dies, that pigment will then find its way out into the neuropil and cause the loss of pigmentation in the substantia nigra. This Lewy body here is the first sign that the cell is dying. It's called Lewy after the name of the pathologist, Dr. Lewy, who was the first to describe these inclusions. This finding is characteristic of what is referred to as idiopathic Parkinson's disease, Lewy bodies in the brainstem. Now, dementia, as we said before, in addition to depression, is common in patients with Parkinson's disease. If a patient with Parkinson's disease develops dementia, there are several different disease entities which can cause this intellectual loss. First of all, it could be diffuse Lewy body disease. Secondly, it could be that the patient has both Alzheimer's disease and Parkinsonism. We know that patients with Parkinson's disease have a substantially increased risk of also developing Alzheimer's disease. Thirdly, there are some patients with Parkinson's disease who develop dementia and don't have Lewy body disease in their cortex and don't have Alzheimer's disease. And we're not completely sure what causes this. It's relatively uncommon, but it does occur. Fourthly, there are other types of degenerations of the brainstem. One is referred to as progressive supranuclear palsy, called PSP, and other diseases that also have dementia as a component. These are relatively rare. And finally, there are some things that look like dementia, but actually aren't. One thing is what is referred to as bradiphrenia, which is slowness of thought. Just like the motor system is slowed down when there is a deficiency of dopamine, the thought processes can be slowed down, giving the patients very long latencies between when you ask the question and when they provide you with the information. That can sometimes masquerade like dementia, but if you're patient when you do your screen, such as the mini-mental status examination, you'll realize that the patient is still actually cognitively intact. It's just that they're very slow as they think about what you're saying and then as they respond to you. Also, depression can masquerade as dementia. In fact, depression is a major problem in patients with Parkinson's disease. Psychiatric problems occur commonly in patients with Parkinson's disease, as we see in the next graphic. 1/4 to 1/2 of patients with Parkinsonism will develop dementia. But in addition to that, almost half of them are going to develop depression. And this depression can be very disabling. It's caused by the death of brain cells in the brainstem that produce norepinephrine and serotonin. Not only do these patients have a hard time getting going because of their motor impairment, but then they have this depression, which is an extra burden. These patients can be very difficult to treat. If you have a depressed Parkinson's patient and they have not responded to 1 or 2 different types of antidepressant medications, then they should be referred to a geriatric psychiatrist for further assessment and treatment. Some of these individuals actually require electroshock treatment to help lift them out of their depression. Improving their depression will improve their quality of life. Finally, 1/3 to almost 1/2 of Parkinson's patients will develop psychotic symptoms if they live long enough with the disease. The psychosis include hallucinations and delusions. Many times these hallucinations and delusions are so disabling that they have to be treated. But remember, the side effect of many antipsychotic medications, especially the older drugs, such as Haldol and Prolixin, are increased Parkinsonian symptoms. Consequently, for psychotic symptoms, we recommend the newer drugs, such as Seroquel, olanzapine, and risperidone. Of the newer antipsychotic drugs, risperidone has the highest potential for producing worse Parkinsonian features. So consequently, we recommend either olanzapine or Seroquel in the management of psychosis associated with Parkinsonism. If simple medications do not help in management of these symptoms, we recommend referral on to a specialist for additional medications that can be used by these tertiary care centers. In conclusion then, Parkinson's disease is a common problem characterized by disorders of the extrapyramidal motor system, which also produce symptoms of depression, psychosis, and dementia. In contrast to Parkinson's disease, in which the damage is limited primarily to the brainstem, diffuse Lewy body disease, as we see in the next graphic, is a disorder in which there is damage not only to the brainstem structures, but also to the cortical surfaces. Diffuse Lewy body disease was pretty much unrecognized until about 5 or 10 years ago, until pathologists such as myself began to realize that we were missing the diagnosis. I'm going to tell you in just a little bit why it was that we missed Lewy body diagnoses. But first of all, let's talk about the incidence in the natural history of this disease. As we see in the next graphic, diffuse Lewy body disease may account for 10 to 20% of all types of dementia over age 65. This means that it may actually be more common than vascular dementia, although these studies have not been completed. In contrast to patients with Alzheimer's disease, patients with diffuse Lewy body disease tend to get the symptoms a little bit earlier. In this one study that's shown by this graphic, the average age of onset for diffuse Lewy body disease was 73, as opposed to the Alzheimer patient where it was 81. More males than females get Lewy body disease, as opposed to Alzheimer's disease where it's slightly more common in females. And likewise, there is a difference in life expectancy between Alzheimer's disease and Lewy body disease. Going back to this study, the average life expectancy in this one study for a patient with Lewy body disease was 2 years, as opposed to the Alzheimer patient, which was 4.5 years, indicating that the life expectancy may be less in patients with Lewy body dementia. There are a few key concepts that you need to keep in mind when you're considering Lewy body dementia. First of all, Unlike Alzheimer's disease, which tends to have a slow, progressive, fairly consistent cognitive loss, patients with Lewy body disease oftentimes have fluctuation of intellectual symptoms. Some days they seem to be pretty much with it. Other days they seem to be pretty much confused. Now, you have to be careful when you talk about fluctuation of symptoms because there are other things that can cause fluctuation of symptoms. Delirium can cause fluctuating cognitive symptoms. And likewise, some patients with Alzheimer's disease get more confused in the afternoon or the evening, a term referred to as sundowning. However, typically the patient with Lewy body dementia will have a few good days and a few bad days followed by a few good days. That type of fluctuation is typically not seen in patients with Alzheimer's disease. Also, patients with diffuse Lewy body disease tend to get hallucinations and delusions early in the disease. Sometimes it's the first manifestation, as opposed to the Alzheimer patient in whom you usually have a history that the patient was really kind of forgetful and sometimes they struggled with their words. That would be the early phases of the disease. And then as they move into the middle phases of Alzheimer's disease, then they develop the hallucination and delusions. The Lewy body patients often will get hallucinations and delusions very early, if not as a presenting symptom. And finally, Alzheimer patients do not have extrapyramidal symptoms. Patients with diffuse Lewy body disease oftentimes have Parkinsonism in conjunction with their cognitive loss. The diagnostic criteria for diffuse Lewy body disease, as published in the journal Neurology, are that first of all, you have to demonstrate that the patient has lost intellectual function, and then you must demonstrate 2 out of 3 symptoms. There must be fluctuation of cognitive function, or there must be visual hallucinations, or there must be Parkinsonism. This is how you diagnose diffuse Lewy body disease. And by the way, you can't have the Parkinsonism if the patient is receiving an antipsychotic like Haldol or Prolixin. Those drugs cause Parkinsonism. In the next slide, we see a contrast between the symptoms present in diffuse Lewy body disease, which is the first column, and those which are present in Alzheimer's disease. As you can see, 2/3 of patients with Lewy body disease had Parkinsonism as opposed to 7% in Alzheimer's. 1/3 had visual hallucinations. Almost half or over half had auditory hallucinations. Almost 2/3 of the Lewy body patients had delusions. And the bottom line, neuroleptic, means that when the person was put on a standard antipsychotic medication like Haldol, 1/3 of the Lewy body patients developed severe motor problems as opposed to relatively few of the Alzheimer patients. We refer to this as the neuroleptic stress test. If a patient is put on an antipsychotic like Haldol because they, quotes, have hallucinations and delusions associated with dementia, and they become severely stiff, you need to worry whether or not they actually might have diffuse Lewy body disease. When you look at the brains of patients with Lewy body dementia, there's no distinguishing feature or characteristic that tells you that, hey, this one's got Lewy body and that one has Alzheimer's. In this graphic, we see on the left an Alzheimer brain and on the right a Lewy body brain. And again, they both look atrophic. Therefore, there's no way to distinguish Lewy body from Alzheimer's on brain imaging studies. Brain imaging like CAT scans and MRIs are not going to help you distinguish one from the other type of dementia. The type of pathology that you see in Lewy body disease then is at the gross level, nonspecific atrophy. Sometimes the brains are not atrophic at all. But at the microscopic level, you will demonstrate cortical Lewy bodies, as well as damage to the brainstem. In the next slide, we show you a microscopic specimen from a patient with diffuse Lewy body disease. Remember when we were showing you the microscopic picture from the patient with Parkinson's disease? There was that nice big body inside the brain cell with the halo around it and the red bullseye in the middle, the Lewy body. Well, believe it or not, in the middle of this field, there actually is a Lewy body. However, it's almost impossible to see using the standard stains that we use in brain pathology. This is what is referred to as an H&E or hematoxylin and eosin stain. There is a Lewy body, and here it is pointed out by the arrow here. And as you can see, it blends in with all the rest of the tissue around it. This is why when folks like myself, neuropathologists, were examining these brains under the microscope, we consistently missed the diagnosis of diffuse Lewy body disease because we couldn't distinguish the Lewy body from the surrounding brain tissue. What happened is we realized that there was a special stain that you could do which would light these bodies up, and that's what you see in the next slide. See this brown blob here and this brown blob here? That's a Lewy body, only stained with an antibody directed against the substance called ubiquitin. And as you can see, when you do a ubiquitin stain, these rascals light right up and they're easy to find. That's why it's easier now for us to identify patients with these Lewy bodies, not in their brainstem, but in the outer surfaces of the brain in the cerebral cortex. These are referred to as cortical Lewy bodies. Patients with Parkinsonism get Lewy bodies in the brainstem. Patients with diffuse Lewy body disease get Lewy bodies in their cerebral cortex, mostly in the temporal and frontal poles. This is the pathological hallmark of diffuse Lewy body disease. Again, to repeat, the typical pathology seen in diffuse Lewy body disease is Lewy bodies in the brainstem, which produces the Parkinsonism and the psychosis, Lewy bodies in the pons, which includes the locus ceruleus and the raphe, which produce the depression, as well as Lewy bodies in the medulla, which also produce the depression. This, in conjunction with cortical Lewy bodies, produces the constellation of symptoms that's so typical of diffuse Lewy body disease. What about the treatment for diffuse Lewy body disease? Well, first of all, we know that we can treat dementia with cholinesterase inhibitors, things like Aricept and Exelon. Do they work in diffuse Lewy body disease? Well, some preliminary studies suggest that Aricept and Exelon may be beneficial in patients with diffuse Lewy body disease, and these trials are presently well underway, and the suspicion is that they will be beneficial. If the patients have Parkinsonism, then you would replace the dopamine just like you do in other types of Parkinsonism with drugs like Sinemet. What if the patient has depression in diffuse Lewy body disease? Then you would treat them with antidepressants, drugs like serotonin reuptake inhibitors. For the psychosis, like in Parkinsonism, we recommend the use of the newer antipsychotics, drugs like Seroquel and olanzapine. Again, risperidone is also helpful, but it has more Parkinsonism than the Seroquel and the olanzapine. And finally, for behavioral problems, we recommend standard behavioral management that you would use in Alzheimer's, vascular, or other type of dementia. Likewise, standard pharmacological interventions for things like impulsive behavior, valproic acid, and Tegretol may be beneficial in patients with diffuse Lewy body disease. However, what should you do in the psychotic patient with Parkinsonism or the psychotic patient with diffuse Lewy body disease? There are studies that indicate that Seroquel may produce less drug-induced side effects of stiffness than other atypical antipsychotics. We recommend starting patients on about 50 milligrams of Seroquel and then titrating them up somewhere between 75 and 100 to see if you can suppress their hallucinations and delusions. Extrapyramidal symptoms, referred on this slide as EPS, are really minimal with Seroquel. However, you do have to be careful of sedation and some mild orthostatic hypotension. Drug-induced Parkinsonism, with regards to motor symptoms, are not generally worsened by this drug, and there are studies that demonstrate that their psychosis is improved with the medication. Olanzapine can also be used. In conclusion, then, today we have reviewed vascular dementia, Parkinson's disease with dementia, and diffuse Lewy body disease. These are several very common causes of dementia in persons over the age of 65. In the subsequent segment, we're going to review other common types of dementia in individuals over 65, including alcohol, frontotemporal, and other types of dementia.